On behalf of the Patient Safety Authority, I would like to welcome you to this webinar, Bruise Weight-Based Errors, Health IT and Safety Culture. My name is Shirley, and I will be your moderator for this program. Now, I'd like to introduce our speaker for the webinar. Steve Mrozowski is the Senior Director of Safety and High Reliability at the Cleveland Clinic. In his role, Steve is responsible for the oversight, direction, and leadership of the enterprise-wide patient safety program, and he leads the patient safety, environmental health and safety, component patient organization, and clinical risk management team. Previously, Steve held positions as Director of Patient Safety and the Patient Safety Officer at Penn State Health Milton S. Hershey Medical Center in Hershey, Pennsylvania. He also has experience as a clinical quality and patient safety manager at Penn State Hershey and as the Emergency Medical Services for Children Program Director for the Commonwealth of Pennsylvania. Steve, I will now turn the program over to you.
Okay, thanks so much, Megan, and hi, everybody. So glad to be here. Hopefully you can hear me okay. And we'll dive right in here. So we're going to talk about weight documentation errors and how all of that ties together with health IT and human factors and safety culture. So some obligatory slides. I have no financial interest to disclose as part of this presentation, and I will be referencing certain products or safety event reporting systems and electronic health records. However, by no means is there any endorsement of any of those brands. And in the spirit of disclosure and transparencies, I feel like I just have to mention my organization affiliation. Megan introduced me as an employee of the Cleveland Clinic, and that is a title I have held for a whopping 72 hours. So much of the credit for this presentation and my references will be tied back to my time at Penn State Health Hershey Medical Center. So just wanted to call that out a little bit more discreetly. Again, the credit for this work is all owed to the fantastic team at Penn State Hershey, and some background about Penn State Health is on your slide here. I won't read all of these to you, but I think now with some recent expansions, it's just under 600 beds within the Hershey Medical Center and the attached Children's Hospital. And then some of our other statistics are listed here. We see about 30,000 admissions a year and about 80,000 ED visits. From a geographic perspective, this is how Penn State Health is currently positioned, and obviously, like many health systems, is actively growing, but we spend most of our focus in that South Central Pennsylvania region around Harrisburg. From a quality and safety perspective, some of the past and recent accolades are on the screen here. We pride ourselves in recognitions with the Joint Commission, U.S. News, and Leapfrog, and I believe somewhere in the 9 or 10 Leapfrog A grade in a row for the safety work. All right, and then the last obligatory slide is, of course, the objectives for today. What I'm hoping to achieve with all of you is to really talk about the interplay between how we error-proof things in safety, how we look at health IT in that space of reducing medical error, and I'll touch quickly on culture. Through that, we're going to have you have the ability to provide examples of low and high impact error reduction strategies, and then I hope you'll be able to leave with at least 2 strategies to reduce weight documentation errors in healthcare. But the last one here is most important. I will not talk for the entire hour. There will be plenty of time at the end for questions and discussion, so please submit those. And I truly believe in this idea of all teach, all learn, and I hope to learn from you just as much as you will learn from me today. So let's go ahead and get started. And I want to start off with a story that really tees up a lot of this work. And the story here is about a pediatric patient who was transferred to the Hershey Medical Center from an outside hospital. This was a hospital-to-hospital transfer. The patient came into our pediatric intermediate care unit with suspicion of of meningitis. And through the intake process, this patient was weighed, and that weight was obtained, and it showed a weight of 27 pounds. Those numbers, 27, were entered into the electronic health record. However, many years ago, the organization made the safety-conscious decision to limit the electronic health record to only metric measurements. So the patient weight was entered as 27 kilograms, which, as many of you I'm sure are familiar, equates to about 60 pounds. It was on that weight of 27 kilograms that IV fluids and some pretty kidney toxic medications were dosed and given. And in effect, we overdosed the patient who we were treating for meningitis. So of course you have to be conscious of fluids, and some of those medications at 2.2 times the intended dose. This patient developed acute kidney failure, had worsening of their mental status, and required an upgrade to the ICU. And in a few slides, I'll talk about the details of that event, but that is really what teed off our focus on patient weight and weight documentation. Now, luckily, this patient was able to recover fully, did not need dialysis, but we then had a subsequent event, a serious safety event in which a patient had significant and intentional weight loss that went unrecognized for about a year and a half, and was only caught when he required admission for malnutrition. So we've had a couple of events with patient weight documentation that has really driven a lot of this quality improvement work. It's probably worth stepping back and just talking quickly about some safety science and the Swiss cheese model that many of you are familiar with and probably use on a daily basis. And just to call out that, as we talk through this presentation, our goal at Penn State was to add slices of Swiss cheese into the Swiss cheese model, additional things that can keep those serious harm events from happening. And we know that in serious harm events, on average, there are 4 to 8 slices of Swiss cheese that all have their holes line up appropriately for an event to get the whole way through. And if you're not familiar with the Swiss cheese model, that's the genesis of it, that the slices of Swiss cheese represent those protective barriers, whether that's policies or procedures or technologies or double checks that try to keep things from happening. But because we are human and we make mistakes, and because we are human and sometimes have weaknesses in our system design, that's where the Swiss cheese comes from. And sometimes those holes can line up and things can reach the level of the patient. If we look at this particular event, in that event with the patient receiving 2 times the medication and fluid that was intended and had to be upgraded, we can almost lay this into the Swiss cheese model. So the first slice of Swiss cheese here was that we had a weak system. We had a scale in a clinical area that permitted the display of pounds. We had an electronic health record that only had a kilogram field and didn't permit documentation of pounds. And I have to just say, probably better stated in reverse. Our electronic health record appropriately limited the selection to kilograms, but the scales did not. There's a people aspect of these slices of Swiss cheese. The team really anchored into the disease, this potential rule out meningitis as the cause of the patient's changes in mental status, and never took the time to sort of question or step back and try to view the whole patient from a higher level. And then from a process perspective, there were not extensive double checks in place prior to giving some of these medications, and then that resulted in harm. What's really fascinating about this story is that there actually is a 4th slice of Swiss cheese. However, it came a little too late in the process. And in our electronic health record at that time, when you enter a height and a weight, it generates a body mass index value. And our systems were designed that wonky BMIs, really high BMIs, generated automatically generated a non-emergent and non-urgent obesity screening by dietary services. Unfortunately for this patient, that fell after the harm had already occurred, but it was a dietitian who came into the room who wasn't really engulfed in the throes of patient care that was able to look at the whole patient with that 5,000-foot view and say, wait a minute, something's not right here. I shouldn't be here for an obesity screening. This patient isn't obese. And that's ultimately how this event was caught. When we looked at this and heard about this event, of course, one of our goals was to figure out how to error-proof this, how to keep this from happening again without relying on a whole lot of human intervention. And if you think about error-proofing on the right-hand side of the slide, of course, in healthcare, one of the things that comes to mind for us is something like medical gas connections, as one of our few examples of where we've been able to truly error-proof in healthcare. And you know, in society, again, other aspects of error-proofing exist, you know, as a result of safety events. When you drive away from the gas pump and you forget to actually take the gas nozzle out of your car, back in the day, that used to result in large fires. And today, the systems are designed so much that you can do that, and the systems will self-seal and not result in fire. And even as simply as the little hose or the little string that connects your gas cap to your car so that you don't leave it on top of the pump. Those are those error-proofing strategies that we strive for. If you look on the left-hand side of this slide, however, in healthcare, I think what we tend to do is get a little too far to the bottom of these lesser effective strategies for error-proofing. The way we respond to safety events more often than not, and there are studies out there that prove this, is that root cause analyses, action plans in healthcare tend to have two very common types of action plan items. The first is to educate. And as you see on the image on the left here, you know, the reliance on human knowledge and memory is generally pretty weak. In addition to education on action plans, one of the common things that's seen is administrative controls, also known as rewriting or writing a policy or procedure. Very common, but not the more robust. And when we look at error proofing, we want to get more to the top of this chart. How do we provide warning devices or other sorts of alerts for people to change their behaviors or act in a different way? Can we control errors with active safety devices, ropes, chains, levers that move in opposite directions, and those sorts of things? And then again, ideally, if we can get to a level of error proofing where it's physically impossible to do the wrong thing, that's our goal. So I just thought I'd spend a second to talk about how we look at error proofing when we think about events like this. Now, when this event occurred, I was a relatively new patient safety officer at our organization, and I thought, well, this is pretty easy, right? This one is probably one where we can get to true error proofing. We looked at the root cause here and realized that we were vulnerable because our organization owned scales at the system level that displayed pounds, an empirical unit of measure. Seemed like pretty low-hanging fruit to come back and say, well, we can fix this. Let's get rid of all of those scales and buy all new scales. And despite being relatively new in my role, received permission to spend a large amount of money to do that scale exchange. And we'll talk later about how that obviously did not fix the problem, or I wouldn't be doing a talk on it. But you know, this was really great. We spent, you know, $500,000 on new scales, and I thought we had resolved this. And you know, there's always workarounds in healthcare. People will find ways to do this. And this was something we could do at the system level because of the cost of medical scales. It's worth noting that since this has occurred, the price of scales has gone down, and they have actually fallen below our level of capital expense at Penn State Health. So there are units and clinics who are able to order scales and circumvent the central purchasing process. So lots of things, and what I hope you get out of these is when you go back to your respective organizations, look at where you're vulnerable. So more to come on this, but that was our first approach. Can we buy new scales? But all that did was really help us start to peel back the different layers of the onion around weight documentation. And then we realized that there's a human component to this. And since we can't do like this alert says and replace all of our humans or our users, we needed to figure out how to supplement our environment change, the new scales, with some technological slices of Swiss cheese that can help our folks do the right thing. And the way we did this was to create alerts that fire for, and I'll go into this detail, but that fire for when weight documentation doesn't make sense or seems erroneous. I have to pause here and recognize that if you can win over IT, you are in much better shape. And to be honest, our IT folks, when we first approached them for this project, were a bit resistant on getting involved and looking at sort of yet another alert or a big sweeping IT change. And I've snipped onto the screen here the email that I received from one of our IT project managers who amazingly has agreed to stay on our weight documentation task force long after his job was actually done. And I'll just sort of read this email to you. I have to say I was on the other side of this. Why on earth would we need to remind people to enter kilograms and not reverse the most simple of items? I have to admit I was completely wrong. Only one of the alerts that he was building at the time was not needed, and that is displayed on the picture right above. You'll see that the height on the first was 91 and 13.2 centimeters, and the patient weight 13.3 and 90.4, and they were transposed. So think about the key players and stakeholders you have in your organization that you'll need to engage, like IT, and they'll be able to see the use case as you present the data. So as I mentioned, one of the first actions that we took was to create a weight alert. The Penn State Health is a Cerner organization, but these can exist in any healthcare record. And we created the alert. The screenshot is there on the left-hand side that there's a possible weight documentation error. And the initial criteria that we came up with was to look at whether or not there was a 20% change or greater from the most prior documented weight. The look back period at the time was 180 days for adults and 30 days for pediatrics. We polled a handful of clinicians to try to come up with reasonable values. There was not a lot of science in this selection, but we know that kids grow faster than adults, so we didn't want to look back too far because we would expect greater than 20% weight gain in some of our younger children. In addition, we had an alert that fired for BMI value or percentile. And like I mentioned, lots of debate here. We went back and forth with various people over what was the right percentage, what was the right amount of look back, and we have since disabled the BMI. The number of patients who fall into those extreme BMIs actually didn't have a lot of incorrect weight documented, and we've changed the percentage for weight change to 30%. And for our adults, that looks back now 450 days so that we can capture the adults who come only once a year for their well checks. And again, 30 days for pediatrics. So it's not perfect by any means, but we did do little cycles of PDCA to make small tests of change when we realized we were getting a lot of false alerts. Making that change to 30% has really helped eliminate a lot of the nuisance alerts that pop up. The alert that does pop up does give instructions for nursing on how to actually go back in and then correct based on the form that they use to document the weight. And I'll show you some data here in a minute about what those alerts have generated. But this is one of a screenshot. The names have obviously been changed. If you're a Family Guy, Meg, Brian, Peter, Stewie fan, the names have been changed here. But this is an example of the automated daily reports that then come into patient safety for review every day. These function a lot like a global trigger report from IHI, if you're familiar with that. But I've highlighted two examples here. And again, we expect with some of our young patients, baby girl SG, that did have an alert fire, a previous weight of 2.4 kilograms, and then a weight of 3 kilograms, a percent change of 27. That is an appropriate alert that can be dismissed. But Tasha, about midway down, had a previously documented weight of 169.5 kilograms, a 30% change as a documented weight of 117. And we'll dive into this particular example here a little bit further. But this is what the alert summary report looks like that comes in every morning for us. When we dive into the specific example, one of the things that we quickly learned was that we're talking about more than just pounds and kilograms transcription, which is what the goal of our original project was. How do we eliminate those pounds and kilogram transcription issues? What we saw here in this example is that patient weight and patient height are being transposed. So you'll see on 122, the patient had a documented, I'm sorry, on 11.6 had a height of 161 and a weight of 117. On January 22nd, those were reversed. And then you'll actually see that they, about 2 hours later, re-entered the values the correct way. They made a correction by entering a new row. And that fires a separate alert because it does actually generate greater than a 30% change when they make the correction. But we quickly realized that we're talking about more than just pounds and kilograms. The point of all of this story here is if you go looking for opportunities for errors, I promise you, you will find them in your respective systems. The work process for us after the daily alert summaries are received to those lists that you just saw is that the patient safety team sends an email to the managers and leadership of those respective areas where the errors happened. And those serve several purposes. They alert the leadership team to errors in their work areas. It forces them and gives them the opportunity to meet with their staff, try to investigate those reports, figure out how and why things happened. It does sort of unintendedly, or a sort of side benefit here, is that it helps to promote the idea of event reporting. And we'll talk about that here in a second, but we did see a great impact on the ability for the patient safety team to have conversation with leaders about what is reportable in Pennsylvania as a safety event. And our organization has been going through a lot of work around fair and just culture and how events are assessed and how people are assessed. And this really gives a great benefit for the leaders to practice their just culture skills. Those conversations with leaders generated a variety of responses, and really, again, gives you as patient safety professionals the ability to capitalize on that, leverage that as an opportunity for conversation about safety culture, what's reportable, fair and just culture. And these are some of the things we heard. Well, we fixed it right away. As soon as the alert popped up, we fixed it. Why would we report it? And that is the doorway opening for you to talk about the definition of near-miss reporting and great catches, and providing the frontline staff the opportunity to identify safety risks in their area. We heard things like we were just too busy and rushed, and that's why this happened. Again, great opportunities for conversations around where you as an organization prioritize safety. And then we heard a handful of, wow, I see now how this happened. I see where my clinic or my floor or my unit is vulnerable. And looking at practices like you see on the right here, right? How many people are documenting on paper towels or pillowcases or gauze pad wrappers and going back and then doing subsequent entry? And what are the risks there? And does that give you a great opportunity to talk to your frontline staff about risky practice? A bit of a refresher for everyone, as you know, on fair and just culture. Again, one of the benefits that we've seen was the ability to have conversations with our leaders about fair and just culture. And as they talk with the person who made the documentation error, did they make that error because it was a simple human error? Were they busy? Were they tired? Was it an inadvertent slip or lapse? And what's the appropriate response there? Consolation, I'm sorry that you were put in that position. Versus risky behavior. Did the person who made the mistake take a risk that they thought was justified, like writing on a paper towel or a gauze pad wrapper and then going back and transposing later? Our responsibility there is to coach and evaluate the systems. And, again, we haven't had much, if any of these, but did the error happen because of something reckless where there was a complete disregard for risk? As a reminder, when we look at fair and just culture, all of that is independent of outcome. So just culture principles have to be applied regardless of whether or not there was harm to the patient on the other end. And reckless behavior still needs to be punished even if no one got hurt. And simple human error or systems-generated human error still needs to be consoled, not punished, even if there was significant harm. So all of these things, these alerts, again, have just been more and more layers of the onion that we've been able to peel back. And then that resulted in us really diving in and looking at our health IT solutions in our electronic health record, and to really see, is there a way for the electronic health record to help address some of these workarounds, and whether or not the record could assist. So we looked at a couple of things. We made some documentations in our record. In the weight method, so the way a weight is obtained, we removed a couple of high vulnerability things. We removed patient stated. We removed other as a way for the record, again, to hopefully drive the right behaviors on the front lines. To go back to our original story, we shortly after we had done that massive exchange of scales for, again, $500,000, we still had an event, and that's when we realized this was not just environment. We had another event, near miss event, and we realized the risks associated with patient-stated weights. So we removed patient-stated as a weight method option. We removed other. We renamed things like estimated and Mrozowski tape to include reference for emergent use only, and the system now prompts you to type a reason why you needed to do an estimated weight, and it automatically prompts a task for a reweigh within 4 hours for those instances where a Mrozowski or an estimated weight is appropriate. And then I would challenge all of you, when you do things like this, you've got to go through and do an assessment and update all of your forms. We found so many forms across our electronic record that prompted for a patient weight. Car seat check forms for when you're discharged from the neonatal ICU or the newborn nursery. Phone call scheduling forms, the ED triage forms. There's forms everywhere that prompt for weight, and you've got to go through and do an inventory and make changes in all of those. Because we're dealing with people here. We're dealing with healthcare workers, and if there is a workaround to be found, we will find it in healthcare. When those changes, like removing patient stated and estimated, took place, for a day, they had forgotten to remove other, which was on the original work order to take away other. So here's just one example. In the one day that this was not caught, we had a weight method of other. The clinician clicked other, and in the other, they typed patient stated because patient stated had gone away. So again, if there's a workaround to be found, people will find it. Be on the alert for those sorts of things. Remember that bad behavior trumps good process every time. So busy slide here, but let's take a look at this middle column. If you look at the second value down, 169.8 kilograms, while every other weight documentation is somewhere between 78 and 88 kilograms. And then look at the weight method comment, you'll see other was selected and free texted was the patient has a bed that weighs. And that was the weight that was entered. It was a patient stated weight based on their home bed scale. If you go, let's see here, third one from the bottom, 36.5 kilograms. I'm sure all of us can recognize that 36.5 is a very appropriate number for temperature. That was typed in the box, but what you'll see in the comment is other spouse reported. So we have a spouse reported temperature being entered as a weight. The other things that are highlighted here, spouse reported, last documented weight. We just took one from a prior encounter and typed it in. So be on the alert for these sorts of things and see where people are getting their sources of information. Is that truly the safest and most reliable pathway for us? Bad behavior trumps good process every time. On this slide, we're going to work our way from the bottom up. So on January 30th, this was a documented weight of 187 pounds per the patient. So the free text even acknowledges we're talking about pounds, but in the electronic record, that 187, those numbers were typed in a kilograms only box. It fires an alert when the appropriate weight here is 85 kilograms. When this was caught and re-entered at around 3 o'clock in the afternoon, it was appropriately entered at 85 kilograms, and then the weight method, though, however, was still chosen as estimated emergent use only for a non-emergent case. Be on the alert for the actions. So all of that to really come back and talk about what we've seen happen as a result. A lot of work, a lot of alerts firing to frontline staff, a lot of sort of nuisance to some of them for sure. But we did see some preliminary results, and this data is a little bit dated, but it's carrying through to today. And this graph shows our event reporting. Now, one of the things that we did here in our organization is create an event type for weight documentation error. On the back end into Pennsylvania Pacers, there's a coding that changes and it turns it into, I believe, an error in billing and records or error other. And so there's a little bit of work for the patient safety specialists to do that data entry. But on the front end, we created an event type that's a weight alert or a weight alert event. And we've seen our event reporting related to weights go up since we've taken all of these steps. When the alerts went live, we had a little blip in event reporting when people realized that that's technically a near miss. When the daily reports went live, that normalized and was increased a little bit. We saw a profound increase when we started doing daily emails to the unit and clinic managers. And then when we made the modifications to the report and changed it from 20% to 30% and started to see things that were a little more clinically significant, profoundly realized that those were real events, and we saw those numbers go up. So you can track your event reporting volumes as a result of changes like this. Comparing the outcomes and looking at specifically near miss harm scores from 2018 to 2019, we saw a dramatic increase in our overall events that were categorized as near misses as a result of this work. And then looking 2017, 2018, 2019, what this shows in the blue bars are near miss events. The orange bars are precursor safety events, or maybe more appropriately, those higher level incidents. And from 2018 to 2019, we saw the flip, where the near miss reporting volumes or classification volumes actually surpassed those precursor events. Really impactful on our patient safety culture when we're talking about what is a near miss, why is it important to report? And we saw finally that flip where our near misses were higher. Some additional outcomes, our emergency department at that time, who had just celebrated a year without a serious safety event, actually began to see a reduction in the firing of the alerts. So this slide is not safety event reports. This is actual alert firing volumes. And it's really a sign that people were starting to change their practices and the way they behaved when the alerts fire less. We presume this to be drilling in the inappropriateness of obtaining patient-stated weights, but we did see an actual reduction in the firing of alerts, which means people are doing it correctly. Some additional outcomes for us. So we've been thrilled to partner with the Pennsylvania Safety Authority and with that team and in Pacers, and the profound impact that this had on our overall reporting volume. So that's been great to share that lesson learned across the Commonwealth and with you all today. We had some unintended benefits in seeing that we could continue our work with clinical engineering. Like I mentioned earlier in the slides, we had noticed that folks were still going around and purchasing scales outside of the centralized approved purchasing processes, and there were scales that were popping up that were coming down to clinical engineering for maintenance that were outside of that appropriate purchase process. When I was a patient in one of our clinics, after the scale exchange had happened, I was weighed on our brand new scales that we had purchased. So it's great. It showed my weight in kilograms. You always like to weigh yourself in kilograms because you weigh half as much as you normally do. But then when I was taken back into the exam room, I noticed under the sink one of those good old-fashioned like 1980s stand-on scales you can get at Walmart, and did an inventory, and there were 12 of those sort of off the grid scales throughout that particular clinic. And that practice site manager and I walked around and threw them all away and talked about why those weren't appropriate to have. So great relationships have been formed with clinical engineering and our materials management folks as we talk about how we acquire new scales, especially in the space of acquiring new practices. As we buy and merge with other medical clinics and hospitals, this becomes a need for you to go back in and do re-inventory and reassessment of new risks that exist when you partner up with other organizations. The other unintended outcome that we saw here was an assessment or an opportunity to look at how we use bed weights, particularly in our inpatient setting. All of our inpatient beds have integrated scales, and some of the alerts that had fired were deemed to be caused by factors associated with the bed scales. And we were able to do broad education across our hospital around consistently making sure the bed is in an appropriate position. Some of the beds, when they're elevated the whole way or the head is up too high, that can actually alter how the bed obtains its weight. And refresh with our staff on things like making sure extra linens and medical equipment are off of the bed before you obtain a patient weight. So a little positive unintended consequence of conversations with nursing and our patient care assistants on how we obtain bed weights. So we have made some changes. Like I said earlier, we changed the percentages, we dropped the BMI, and we proved that just looking at patient weight yielded valuable data for us, to the point that we've now been able to go across and expand the logic of the weight alerts to more than just patient weight. So here's a copy of the new daily report that comes through that talks about obviously the patient age and the alert to date. But the logic, the math of those percent changes now doesn't just compare the previous patient weight to the current patient weight. It will compare the current patient weight to the prior medication dosing weight and compare the previous medication dosing weight to the current medication dosing weight. So we have two weights, as many of you I'm sure do in your system, of patient weight and med weight. So it's actually now a 6-way slice of that data where each of those elements is compared. So that 30% is starting to capture documentation errors in more than just the patient weight field. This has proved very valuable for us as far as understanding where our errors are happening. And specifically, this is some of our data. This is more recent data, just this past quarter of 2021, March to June. And we're starting to dig in now on more than just the fact that these alerts are firing, but really trying to invest some time in the whys. And you'll see some examples here on the left-hand side as to what was the contributing factor to the weight alert. And a couple that I'll highlight for you. Charted under the incorrect patient. Our organization permits you to have more than one patient record open at a time. And there's risk associated with that. In this quarter alone, just these 3 months, there were 23 weight documentation errors. Not any other kind of documentation error, but just weight documentation error associated with being on the wrong chart or tabbed to the wrong chart. The organization continues to assess the risk and the value or the benefit of having or allowing multiple charts open at the same time. 67 of the total, and there's about 300 weight alerts in this quarter, but 67 of them were height in the weight box. 16 of them were temperature in the weight box. And then 174 of them were simple typos. And that's the value of the alert. If people slow down and read the alert, is they were simple typos. When we looked at the typos, most of the typos were retyping the patient weight into the med dosing weight field, where a number was omitted or the decimal point was put in the wrong spot. And we are now doing some deeper dives into what is the value of the med dosing weight, maybe specifically in the ambulatory outpatient clinics. Do they really need to type the same number twice? And are we vulnerable because it's a manual retype of that number? So more performance improvement projects to happen as a result of this. But when you really start to look at your data, I would encourage you to look deep, because you will find opportunities, you will find sub-projects, you will find other causes of your errors that you weren't expecting. So in summary, and to talk about some downstream effects, again, one of the other things that I would ask you, a rock I'd encourage you to turn over and to look at is think about other places in your electronic record where data is populated by the values entered by other people. So specifically, I know that was sort of confusing. Specifically, we have physician notes, those visit summaries or depart summaries or progress notes. And the electronic record allows you to pull over data from fields entered by others, maybe by nursing. And now you might have bad data in more than one place. And if you correct it later in those discrete data fields, does it carry over and fix those notes? So we saw a lot of free text notes where people drug over other data and it turned out to be incorrect. So think about, how does that, where are you vulnerable there? Where are you vulnerable in some of your things like pay for performance metrics or quality metrics that look at some of those discrete data points? So to bring it home, this is not just one thing, right? There are people, there's health information technology, there are processes that all need to be assessed when you look at things like this. And turn over as many rocks as you can. Don't just try to fix one like we did. We thought just buying new scales was going to solve this problem for us, and we completely overlooked the human factor of things like asking for patient stated weights. So turn over as many rocks as you can at your organization. I promise you will find things. If there is a workaround to be found, healthcare people will find it. It's a great trait, but also a great opportunity for people to circumvent the corrective actions or those systems fixes that you try to put into place. A little nod quickly to workarounds, though. Remember, not all workarounds are bad. Workarounds can be a great opportunity for you as patient safety professionals to look at where things could be done better in your systems. The frontline workers tend to be the experts. They may have a better way that just hasn't been explored yet. So keep that in mind when you think about workarounds. Consider the downstream effects within the electronic health record. We just talked about that. Does the data entered by person A populate into notes or documents or printouts made by person B? Think about those things. And all of this has to be looked at and assessed and improved on a foundational culture of high reliability. This can't be punitive. You've got to embrace fair and just culture principles. So you have people, you have technology, and you have processes, all to look at here as you go through this. So as promised, I wanted to leave enough time for questions, and we have about 15 minutes.
I do see a question in here already, Steve. It says, I would be interested how this project has expanded to capture health visits in outpatient settings, especially patient-stated weights, like blood pressures and blood sugars as well. They may be check or tracking at home.
Yeah, thanks, Megan. Great question. And the short answer is that it has not yet. That is an area that's still vulnerable because it is a patient-reported weight over a phone or a teleconference appointment. So we do still rely on the staff to be diligent as they receive that information, as they type it in the record. There are some programs that we do equip patients if they're getting chronic care. So some of our chronic diabetes management, our heart failure program, our transplant programs, I do know that we send patients home with scales that are kilogram-only scales, and we educate them on those risks of pounds and kilograms. But Geraldine, who had asked that, great question, and that's still an opportunity for us. We have worked very closely, though, with our telehealth program administrators on what is reportable, the definition of a near miss, and those sorts of things. So hopefully that will continue to spread, but a great question, and we're still vulnerable there.
Okay, thank you. Yeah, so many things to consider, and it was just amazing to hear all, like you said, the rocks that you kind of uncovered, thinking that you had it handled by just changing out the scales. I do have another question here. It says, what thought or decisions went into establishing the weight percentage change and BMI criteria? And I think maybe you have talked about that, but if you could revisit that.
Yeah, absolutely. And that was probably the least scientific aspect of this entire project. We established a weight alert task force, and on that was a very diverse representation of pediatric physicians, adult physicians, our chief quality officer, our quality and safety leaders, both in the inpatient setting and the ambulatory setting. You know, to be very simple with it, it was an educated guess at first that 20% and those look back periods and the BMIs, we wanted to start collecting data and then make adjustments from there. So that's where the 20% came from. And that's why it pivoted to 30% and adjusted the look backs and eliminated the BMIs. There was a lot of debate. And then I will say, just sort of additionally, when you start to create programs like this, you be on the alert for folks who are also trying to benefit. We had folks who are, I believe it was either diabetes management or obesity clinics that were trying to get one-offs or get unique data out of this. And we had to be very deliberate to keep an eye out for scope creep and look at the fact that our original charge was to look at pounds and kilograms transcription issues and how do we reduce those. So be very thoughtful about how you allow sort of those one-offs to creep into your project, at least until you get your data accurate. Thanks, Megan.
Yeah, no, I have another question here. As beyond weight documentation, what other risks has the organization identified within the EMR?
A great question. I think I hit on one of them that is near and dear to my heart, and that is whether or not the electronic record allows you to have multiple patient records open at a time. We had a few instances in our organization where we scaled that back to only allowing one open at a time, and as a result of coding issues and programming issues. But today, you still allow you to have multiple patient records open at a time, and that is a risk. That's a risk from a practice perspective. It has caused us as an organization to really look at the balance between productivity and efficiencies or claimed efficiencies and safety and the protection of our patients. And each organization has to make that educated risk assessment on their own as to whether or not the throughput and the flow of your patient day warrants something like that, but arguably I would challenge that that's a risky procedure. And then sort of it was hinted on things like copy forward documentation or copy and paste documentation, or using templates. We look at all too many records where you know, it might be typed, "It was my pleasure today to see Mrs. Smith, who is an _year-old _ with a chief complaint of _." And if you have data fields that are populating some of those templates, just be cautious. I'm seeing one, Megan, I can take. We have been seeing a huge decrease in our event reporting, especially since the beginning of COVID. How have you encouraged these to be done by your staff? And we saw the same decrease in event reporting. We track this specifically actually as a ratio of our patient census compared to your event reports. So if you walk those lines side by side, does your event reporting match based on your patient volumes? And now that we have rebounded post-COVID with our patient volumes, we had noticed some divergence between patient volumes and safety event reporting volumes. That has done just as you described in your question, of deliberate conversations, making sure reporting is encouraged by leaders, is present on huddle boards. You share stories, and you share stories where successes and changes have happened because of event reports, and that will encourage people to continue to report. And in our organization specifically, everybody does get a feedback email or an email in response to not only thank you for submitting your report, but here's what we did with it, so that you can continue to combat that. But I would just say you've got to be aware of, and it sounds like you are, to whoever submitted that question, that your volumes are down, and we get it. COVID has exhausted all of us. People are very busy and understaffed and overworked, and that's all the more role of the leader to step back and say, this is why reporting is still important.
Has your hardwired height and weight for surgical patients on the day of surgery? Has your hardwired height and weight? And if
So
so,
I'm going to
how?
assume that has your organization hardwired this, and we do. All of our pre-op, if I'm answering the question correctly, all of our pre-op processes do obtain new weights and heights on the day that they check in.
Great presentation. Someone says, how did you do your education piece? I am sure it was multimodal.
Absolutely correct. This is embracing that 7 times 7 different ways strategy. So we continue to bring this data back in front of people as well. So it was education prior to the alerts going live as to what they mean. All of our staff are required to take safety event reporting training, which includes an elaborate section on the definition of near misses. And this data gets shared frequently to a variety of groups of both frontline staff, our shared governance teams, and our leadership teams, so that it's out there, and the value of an alert can be shared. I think we all know that alerts can sometimes be nuisance, and we've all seen our fair share of clinicians breeze by an alert without even reading it. So this really gives us the opportunity to have those conversations.
I had a question myself. I was looking at one of the slides in the beginning where you were talking about the alerts that are popping up if in fact something doesn't look right that's been entered as a weight into the entry field, and it looked like there was some like red text that came up. Did you find that there was any, and is there any override to that? Like if I'm just thinking outside the box, like somebody's busy, they see the alert and they may disregard it for whatever reason. Have you found that kind of a soft stop? I was just curious.
Yeah, we do see that. I don't know that there's data on that, Megan. That's a great question we can look into later and learn more about. There is an approval process for whether an alert is a hard alert or a soft alert. These ones are soft, so they can be bypassed. And some of that was on the basis of not everyone does require a change. Some of the pediatrics, again, we expect them to grow 30% in the NICU and those sorts of things. So we didn't want to make it a hard alert that required people to sort of stop their workflow. Right. But that's a great question as to whether or not there's data on how long an alert is up. Is it enough time to actually be read, or is it dismissed without being looked at?
Yeah, no, I'm just curious.
Great question.
Another question for you, where there was an entry and it was incorrect, it was switched, I think, like height and weight in one of your slides, and then they went back and they corrected it for that same day at a different time. Do both of those height and weight, the correct and the incorrect for that date, still show up?
They do if they're not corrected the correct way. So again, I can't speak to other platforms other than Cerner, but if the way that it was fixed was to just make a new entry, they would both show up because they would both show as alerts because they would both be greater than 30% changes. The proper way that in that software we want them to be edited is to have that erroneous error modified to be corrected so that the wrong one doesn't linger in the chart. But we still see a fair amount where the correction actually fires an alert all on its own.
Here's just a question about Penn State Health is a magnet organization.
Penn State Hershey Medical Center is a magnet hospital.
Yeah.
And my email address is on the slide deck that I believe will be made available to everyone if it wasn't already sent out. So happy to entertain other questions by email after today. That's perfectly great.
Oh, great. Great. Thank you. I do want to thank everyone for joining us today. If you experienced any issues accessing the evaluation and/or certificate of continuing education, please feel free to direct any inquiries to Shelley Mikeful at shmixell@pa.gov. This concludes our webinar. Thank you.